Hi guys, it's Sherry again. We're going to talk just real briefly about trauma to the head, neck, and spine. Okay, so let's review real quick our nervous and our skeletal systems. Our nervous system controls our thoughts, our sensation, and our motor function. It comes in two parts. Okay, the central nervous system, which consists of, I have the hiccups, of our brain and our spinal cord. And then everything else that branches off the spinal cord is part of our peripheral nervous system. Peripheral meaning outside or to the extremities. So that includes our vertebrae nerves, our cranial nerves, and the nerves out to our motor, to our muscles and our extremities. Okay? And you can see here the pink is the central nervous system. And all the green is our peripheral. And there's a lot of peripheral, but obviously the central plays a huge part. If something happens to that, then none of the green stuff works. So, anatomy of our head is our cranium, which is our skull. Okay, and there's several plates to that. And I'm not going to expect you guys to know all of that, other than the fact that you know it comes in different parts. And they all should be intact. Okay. Facial bones, there's 14 of those. Some of those that we're going to talk about that are important will be your mandible, which is your upper jaw. And then you have a temporal bone. If you've ever heard of the condition TMJ, which that hinge in your jaw doesn't work correctly and it causes a lot of pain, that's that temporal mandible joint, TMJ. So that's that jaw hinge. Your bottom jaw is your maxilla. And then we have our nasal bones, which are not necessarily bones. We have some cartilage in there, but the bones around our cartilage are our nasal bones. And then our zygomatic, that's your cheekbones. And behind that sits your sinuses and then your orbits, and that is what forms your eye socket. Okay. We have our spinal cord, which comes out of our brain through the base of our skull, and it comes through a hole called the foramen magnum, and that is the only exit point out of our cranium. Okay, otherwise our brain is pretty well socked in there. So if our brain decides that it wants to exit our skull, like maybe because there's too much pressure inside the head, the only way for it to get out is to push through that foramen magnum. Okay. Now another part that is going to be important to know is your cerebral spinal fluid, and it's abbreviated with CSF a lot. This is important. Your cerebral spinal fluid bathes your brain and it circulates down the spine. So it's kind of the lubricant and this cushioning around our brain and around our spinal column. It should be intact. It's an enclosed circuit. So our cerebral spinal fluid should not go anyplace else except around those two systems. If it leaks out, then we have a problem. If we have leakage of that cerebral spinal fluid, then we probably have damage to either the spinal cord or the brain or both. So we're going to talk a little bit about how to recognize that. Okay, so here's our cranium. We got all kinds of good stuff here. Your parietal bone, the frontal bone, your occipital bone. And if you feel the bump in your head, you're going to have a bump that kind of runs about the top of your ear, around the back of your head to the top of the other ear. So there's kind of a ledge, a drop-off point there. So that bone that is that drop-off point is your occipital bone. And that is where your eyesight sits, is right back in there. So I'm going to let you just take a look at that in your book rather than spending much time on it in here. Okay, so looking at our spine, which is the other part of this system, we have our cervical spine. There's 7 of those. We have our thoracic, cervical being in the neck. thoracic, which comes from the neck down through the chest. There's 12 vertebrae in there. There are 5 vertebrae in the lumbar, which is our lower back. We have 5 sacral vertebrae, which goes down lower into our hip area. And then down your coccyx, those are kind of fused together, so there's some debate whether there's 4 or 5 of those. But your coccyx is basically your tailbone. Okay, and I remember these because if you look, it says 7, 12, 5, 5, and if you think coccyx is 5, if you look at the Iowa phone numbers, okay, it's always 712, so there's your 7 and 12. And then 555 is always in the movies, you know, everybody has a number that's 712555 something. So if you can remember that, this 4 is a little bit argumentative. Some people say 4, some people say 5. Since they're fused together, it's really very hard to tell. So, and each of those has a spinous process or a avenue for peripheral nerves to come off of there. This is a picture. Can you see how this is curved? Okay. The thing is, we always try and put these curved spines on a flat, long spine board. And that just doesn't work very well when we're trying to keep them in their natural position. So, although we talk a little bit about padding the voids, we sometimes don't practice it as much as we should. And if you can look at this picture and see, there is a great need to pad the voids to make sure that we keep these patients in line like they should be. Okay, so here's your 7 cervical, 12 thoracic. You can see there's a lot of them there, and it goes clear down past our rib cage. We have these 5 lumbar in our lower back, our sacrum, and then way down here is our coccyx. And you can see they're very fused together. Okay. So let's talk about injuries. Okay, some things that we can have happen to our patient. This is kind of a graphic picture. Looks like a fairly young child. And I apologize if it's a little gross, but it's what we do in EMS. Okay, so we can have 2 types of injuries to the head. We can have scalp injuries, which are basically lacerations to the scalp. They bleed a ton. Okay, you can have a small cut to the head that will bleed like everything. And again, can be a very distracting injury. If it is only a laceration to the scalp, it's not usually life-threatening. But it's with all the bleeding, it tends to get our attention. The other thing is, if you've got somebody with a hat on, or a large amount of dark hair, or a parka head on, or a parka hood on, they may bleed quite a lot without you being able to recognize it. So when I'm dealing with a trauma patient, I always take my gloved hand and run it like from the nape of their neck up into their hair, and then pull it out and look at my glove to see if I see any bleeding, because it is sometimes easy to miss, even though they do bleed profusely. The other thing that we can have is a skull injury, where we have either an open skull fracture or a closed head injury. And this one is an open skull fracture, where we can see the thickness of the tissues here. But then we also have this broken skull here, so we can actually see down into the brain or the gray matter there. Obviously, if we have that going on, our patient is in serious danger of not surviving. Okay, so direct injuries that would happen to the brain would be the brain is lacerated, punctured, or bruised by broken bones or foreign objects. So this would be a very sharp stabbing knife, maybe a gunshot wound, maybe a penetrating injury where something was actually penetrated through and into the brain. Not a good outcome for a lot of these patients, but depending on what part of the brain is injured, they may stand a better chance than other times. Indirect injuries to the brain is more like a blunt force trauma. So we have an injury to the skull, And that we know from studying the way energy works that energy doesn't go away. So if we've got energy that's moving an object forward and it hits our skull, that energy goes through the skull and continues on. It doesn't stop. And so when that happens, it causes injury to our brain that could be in the form of a concussion or a contusion, which is a bruise, and we all know that bruises swell. Now, the interesting thing about our skull is our brain sits in there and it perfectly fits. Okay, so there is no extra room. We call the space between the brain and the skull potential space, meaning something could come in there, but something else has to give for that to happen. So it actually is a perfect fit, except for our geriatric patients. And later in life, our brain starts to shrink. And so when our brain starts to shrink, then we have the capability of our brain kind of sloshing around inside of our skull, which adds for a whole new set of problems that it can become more damaged more easily because it's not tucked in there nice and snug. Our brain can actually slam against the side of the skull and cause tearing and bleeds. So any traumatic brain injury is an injury that disrupts the normal function of the brain. So a concussion, those range, we hear a lot of talk about those in our contact sports now, especially football. So we can have a very mild concussion, and really we don't see a whole lot of outward signs of that, all the way up to a serious concussion or a coma. And then our contusion, bruising is often caused by what we call coup or counter coup. And that's when a force hits our brain and that pushes, or a force, hits our skull, and that pushes the energy into the side of the skull, which pushes the brain one way or the other, and then that all bounces back. So it's coup, counter coup, which are French words. It makes you sound really smart when you say those. Okay, and contusions cause swelling, and like we said before, there isn't extra room for swelling. So the only exit point for our brain is through that foramen magnum. Unfortunately, the part of the brain that is closest to that opening is the base of the brain. And in the base of our brain is where all of our involuntary movements are created, or involuntary actions are created, like breathing and heart rate and blood pressure, vessel size, those types of things all originate from that brainstem. And so if the upper part of the brain swells and there's no room, it actually forces that brainstem down through that tiny little hole and causes it to become strangulated and lack circulation, because it's starting to pinch off the arteries that are coming up into the brain, and very soon causes death. So closed head injuries, here we go, concussion. Mild concussions, not a lot of detectable stuff. Sometimes you may see a patient that, especially let's take football for instance, because that's probably the most common. They get hit, maybe a very brief loss of consciousness, maybe not so much that they even know it. They're a little bit groggy. They have short-term memory loss, which is very common, and a headache. Okay. There are measures now that we take with our athletes, and there is a baseline test that they're going to be asked to take when they start into a contact sport. And it's a series of things that they have to go through, very, very simple, rudimentary, and from talking to people that have taken it, I think it's quite an extensively long test. And it's, you see this, and what is your response? What is your response? What is your response? So when you have a normal brain function, it seems very simple and kind of almost silly to have to go through that testing. But then once they've sustained a brain injury, they go back and retake that test, and they have to be at a certain level before they'll be allowed to go back in and play again. It's amazing how much a slight injury affects your brain function. So it's very nice that we have this tool, because a lot of our high school and college players were getting set right back into the game without anybody ever realizing how damaged and how hurt they were. So a contusion is usually recognized by an unconsciousness, period of unconsciousness, or a decreased level of consciousness for a while, and they don't bounce back from that real easily. There's some bruising in the brain, the swelling starts, and they will deteriorate as time goes on. Okay. So things that can cause a traumatic brain injury are lacerations to the brain, like we talked about, a hematoma, which is bleeding in or around the brain. So we're going to talk about a couple of those here. So here is a subdural hematoma, and here is an epidural hematoma. Okay, so subdural, there is a layer around the brain called the dura mater. Okay, and if that bleeding happens under the dura mater, now it's not in the brain, it's between the brain and the skull. You can see where this side of the brain is all where it should be. Because of this bleeding here, it's actually pushed the brain over. It can cause the whole septum of the brain, which is right here, to shift, and it's actually going to push that brainstem down through that foramen magnum if this pressure gets to be enough. Okay. And like we said before, there's not room for anything extra in this space. So this one is called an epidural hematoma. Okay, it's above the dura mater, so it's between the dura mater and the other lining there. And there's lots of vascular structures here also. Okay, and then this one is called your intracerebral bleeding. And this is actually a vessel inside the brain that has become torn or ruptured, and it's actually bleeding into the brain. All three of those are going to cause what we call increased intracranial pressure. And we're going to see that by usually a headache, altered level of consciousness, and when the pressure becomes big enough, or pressure becomes enough, we'll start to see some significant changes. And one of those is called Cushing's triad. And so that's when the heart rate goes down, but the blood pressure goes up. Things happen opposite of what we think it would. So if you see a low heart rate and a high blood pressure, start thinking head injury, because that's, and then look at their breathing pattern. Cushing's triad also has an erratic, irregular breathing. And what we'll see with that is what we call Shane-Stokes. So they'll breathe rapid and deep, and then they'll slow down, then a little period of apnea, and then rapid and deep again. And they'll continue that pattern for a while. So all three of those are indicative of increased intracranial pressure. Okay, so BSI, we need to think about if they've got a head injury, do they have a spine injury? Most of the time, these patients need to have C-spine and a C-collar replaced. We have to watch their airway. Okay, that'll be one of the first things that becomes compromised, if it isn't already, is their airway. Okay, again, look for changes in their breathing. A C-collar probably most of the time would be appropriate. If there's any bleeding, oftentimes with an internal head injury, you'll also have an external bleeding from the force that was applied. And we want to keep these patients at rest. We want to keep them calm. We want to keep them laid down. We don't, however, want to put them in what we used to call the Trendelenburg position. We used to tend to put their feet up so that we tried to get more oxygen to their brain, And what we ended up doing was causing more problems than good. So they're just going to be laying flat or maybe very slightly elevated. Okay, so if your patient is conscious, talk to them, give them some emotional support, let them know that you're going to do everything you can. If there's any open wounds, dress them. If they have a penetrating object in their head, face, or neck, we're going to stabilize it, unless it's going to compromise their airway, to leave it there. So if it's in their cheek or nose or someplace where we can't maintain their airway or manage their airway, then we're going to remove that. Otherwise, it's going to stay stabilized and in. Okay. Package that with some bulky dressing and make sure you secure it nice and tight. Okay. We're going to manage these patients for shock because they are at a very high risk of going into shock. Okay. Other thing that they're at a high risk for is vomiting. So make sure when you package your patient and you transport them, you, number one, have whatever you want, their emesis basin or bag, but also that you can turn them on their side very quickly, because we don't want them aspirating that down into their lungs. So we're going to transport our patient very promptly. These patients, if they have a head injury, are high priority patients. Generally, they'll have an altered mental status or will have had an altered mental status at some point. So that's going to put them in the high priority patient category. Okay, and because of that, we're going to monitor their vital signs every 5 minutes. So when a hematoma develops, we talked about this intracranial pressure just a little bit. It's going to show up by altered mental status for our patient. If our patient is talking to us, they may tell us that they have a very big headache, and then they'll start to become a little groggy. With some patients, they may go unconscious and then come back and then go unconscious again. If that happens, we probably have a brain bleed. So that consciousness, unconsciousness, and then back again is a big indicator. However, it's easy to miss. So it's not that they're just relaxing and going to sleep. If they've been damaged and they have a head injury, they probably are going to be shook up enough they're not sleeping. They go to sleep and then they wake up. We have to think head injury. Okay. Sometimes our brain bleeds are slow. If it's a small vessel, it may take a while. Especially if it's a vein, it may take quite a while. If it's a tiny, tiny little artery, it may take a little while. If it's a bigger artery, it's going to happen pretty quickly. So depending on where it is and what vessel has been damaged will determine how our patient presents. Sometimes these patients with subdural hematomas can be normal for a week or two, and then they start developing headaches and nausea and vomiting, and oftentimes they don't relate it to an injury that happened a week or two prior. And I took care of a 24-year-old man, came into the ER, passed out. Wife couldn't wake him up, and he'd had, I can't remember what it is, some type of injury a couple of weeks prior, but when she brought him in, we ran him in and did a quick CT of his brain, and he had a huge subdural hematoma and died later that night, and 24 years old. So very sad when that happens. Okay. We're going to see a rising blood pressure and a slowing heart rate as we talk to this. And that's that Cushing's reflex. Cushing's triad is when we see rising blood pressure, slowing heart rate, and that erratic breathing. Okay? So if you can keep in mind that the pupils are always the window into your brain. Okay? I know it's supposed to be into your soul, but it works for your brain too. So if their pupils are dilated, and they shouldn't be, that's a big indicator that we have increased intracranial pressure. Or if when we shine the light into our patient's pupils, they react, but they're slow. That's also another indicator. Okay, we talked about that Shane-Stokes breathing where they breathe really fast and rapid, and then they slow down and have a little period of apnea, and then they start all over again. Big sign there. Okay, ataxic respirations are, like we say, erratic, and then decorticate and decerebrate posturing. Okay, we're going to see this when that brainstem starts to perforate down through that foramen magnum. Okay, so decorticate is, and I wish I'd have put a picture in here for you guys, but I think there's one in your book. Decorticate is when your patients draw into the core, so they kind of go in that fetal position a little bit. Their arms kind of pull in to the core, their chin comes down, and they kind of tuck up in that fetal position. And then decerebrate is the last, and both of these are very late signs. So, but when they start to kind of go into that fetal position to the core, and then as the brain continues to herniate, I call it giving it up, and they start to arch their back, extend their neck, and their arms go out, kind of out, and they turn outwards, like their palms would turn towards their back. And when you see that, that's a pretty ominous sign of too much intracranial pressure. Okay. So if you've got things in the head, like penetrating objects, we're going to stabilize that object in place if it's still sticking out. If we have to cut something off, say you've got a piece of rebar through there, a couple things you want to consider. Okay. Cut it with something that's not going to cause a lot of vibration. And if you're going to use, like, say, a torch, you want to make sure that you're cooling that rod at some point between the patient and the heat, because otherwise that heat will travel down the rod and it will cook all the tissue around, all the patient's tissue that's around that object. So you may need to continuously pour water on the object if you're using a cutting torch to cut it. Okay. Injuries to the face and the jaw. Like I say, if airway is compromised, we're going to remove an impaled object. Okay. We want to be really, really careful that we have suction nearly full time on these people. If your patient is conscious, give them the suction catheter and let them suction their own mouth. They know when they have secretions, when they need to spit. But if we've got especially blood and it goes down in your stomach, you're going to vomit because your stomach does not do blood well, and it will get rid of it. Then we run the risk of a very much damaged airway because now we've got vomitus in the airway. So turn your patient on the side if you can. Maybe prop up the long spine board kind of at an angle so your patient can drain out. Give them the suction catheter. If nothing else, assign one of your team members to the airway, and their job is to keep that airway suctioned. Okay. Sometimes what we have a brain injury, and it's non-traumatic, such as a stroke. Okay. If we have a stroke, that is a brain injury, and it's caused by either a hemorrhage, a vessel that has burst in the brain, or a blood clot that has occluded a vessel in the brain. Either way, we're going to have a section of the brain that's not being oxygenated. Okay? With the hemorrhage, we run the additional factor of that we've got increased pressure. Now we've got bleeding into the brain when there isn't room for that extra blood in there. So most strokes, like 85%, are caused by blood clots. But sometimes you will run across the hemorrhage, and those are going to be, both of them have neurological deficit, but the hemorrhage strokes oftentimes are characterized by a very sudden, horrible headache. And then when that vessel bursts, they get this tremendous headache, and they usually tell you it's worse than anything they could imagine. So these are going to have the same signs and symptoms as our traumatic brain injuries, only without the trauma factor. So they'll both have neurological deficit, maybe periods of consciousness, unconsciousness, and an altered mental status. So we're going to use our Glasgow Coma Scale on a lot of our trauma patients, but specifically those with a head injury. And this helps us be able to communicate to the receiving facility what our patient's condition is. So we're going to use AVPU. So like AVPU, we're using the best response that we can get. So if our patient is alert and talking to us, he gets an A. He's alert. Okay. He also qualifies for most of the others. He's also verbal and painful and all that, but we're going to go with the best response. So in our Glasgow Coma Scale, we're looking at some specific things. Eye opening. And I'm sorry. I'm going to refer you to your textbook on this to look a little more closely, but we're looking, do they spontaneously open their eyes? So do they open their eyes and look at us? Or do we have to verbally stimulate them and tell them, open your eyes, and then they will? Or do they not open their eyes at all? Okay. The next thing we're going to look at is their verbal response. Okay. Are they orientated? So they're talking and they're making sense? Okay. Or are they talking but they're confused? Or are they talking but using inappropriate words? So this one, the confused is they are confused. They don't know where they're at. They're not where they should be. This one, they're just not making sense at all. And this one, they're not even saying words. They're just making incomprehensible sounds. Or they could have no verbal response at all. Okay. Then we can look at motor response. Do they obey your commands? So you can you say, squeeze my fingers, and they do it. Okay. Or do they only use motor response to recognize pain? Like, let's say you do a sternal rub on them and they reach up and swat your hand away. Okay. But they're not following commands. That would be localized pain. Okay. If you don't get them, if they're not swatting your hand away, or maybe you pinch their skin and they do that. If you do a sternal rub and they kind of try and pull away from you, like they shrug their shoulders in trying to get their chest away from you, that's withdrawals from pain. Okay, and then the last one can be posturing after painful stimulation, or no motor response at all. Okay, so each of these are given a number. So in motor response, we have 6 possibilities. In verbal, we have 3, 4, 5. We have 5, and here we have 4, and in eye opening we have 3. So we get the highest in each one of those. So let's say our patient is opening his eyes spontaneously, but he's confused and localizing pain. So we're going to give him that 4, 3, and 3. Okay. And that would be his Glasgow Coma Scale. So look that up in your book, get a little bit familiar. If you have a response guide, EMS field response guide, those are in there, and I encourage you to learn those. If you take a patient to a trauma center, they want to know the Glasgow Coma Scale in your report. So make sure that you have that ready when you call in the report to the hospital, because it will help them know without a lot of words how your patient is doing. Okay, so let's talk about wounds to the neck. If we're going to consider wounds to the neck, much like we would a sucking chest wound, okay, and we're worried about sucking chest wounds because it pulls air into that airway system. And those injuries to the neck, if they penetrate through the skin, there's large veins and arteries close to the surface. So we could have some serious bleeding. If your jugular vein is cut or your carotid arteries are there, we could have serious bleeding issues. So in our large veins, our pressure is lower than the atmospheric pressure. So if we have a vein that gets cut, like our jugular vein in our neck gets lacerated, it's a very low pressure vessel. Okay, so the air outside will push its way into that vein. And if that happens, then we run the risk of getting an air bubble in that vein that's going to go into our pulmonary system, and that works just like if we would run a whole IV tubing full of air in. It's going to cause a bubble in our system, which works very much just like a clot in our veins and can cause what we call an air embolus and can be fatal. So wounds to the neck, we're going to stop the bleeding and prevent an air embolism. So to do that, we're going to put a gloved hand over the wound. We're going to treat it just like a sucking chest wound. We're going to apply an occlusive dressing there, so something that's non-permeable. It's either that Vaseline gauze or a gloved hand, a piece of saran wrap, a chest seal, something over that, and then put a dressing over the occlusive dressing to keep it clean. Okay. We want to apply pressure to stop bleeding, but make sure it's not so much that we occlude the blood flow to the brain. Okay. And then if we think we may have a cervical injury, we're going to transport using spinal precautions. Okay. So injuries to the spine. We're going to look at these based on the mechanism of injury. How much force and what kind of force and where was it? Okay. So our spinal cord is the relay between our body and our brain, and damages or injuries to this can be significant. So a lot of data has showed us that injuries to the spine and to the spinal cord happen at the point of impact. And that little we can do after that is going to make that damage worse. Now, that being said, we tend to err on the side of caution. So we're going to take precautionary procedures. But if you've got a patient that needs to be extricated and they have other issues when you do your primary assessment, take care of those before you worry about the spinal precautions. Okay? Those things will kill your patient much quicker than any issue that you have with your spinal column will. So take care of your ABCs first. If those are stable, then we're going to look at our spine and take care of that. Some things that may cause cervical or spine issues, diving injuries oftentimes cause cervical injuries. So if you've got a drowning in the pool, we're going to use spinal precautions on that patient. We're going to hold C-spine, get them out on a long spine board, and use full body precautions with those. Okay. If you have an automobile accident in which you've got this, what we call starring on the windshield, that the patient flew forward and their head hit the windshield, and you'll see that starring effect. If you see that and their head hit hard enough to break the windshield, we're going to consider C-spine on them. Okay, and then whiplash injuries, where these happen a lot of times when people are rear-ended. Okay, so the impact comes from behind, the patient goes forward, and then they recoil back. So you've got that forward and back whipping. Those can cause sometimes significant spinal injuries. Okay, so assess the mechanism of injury and the physical condition of our patient. We're going to consider the mechanism of injury. Okay, but look at your patient. They're going to tell you a lot. So things that we're going to consider high risk. Okay, falls greater than 3 feet, okay, or if they fell down more than 5 stairs, we might consider that high. Okay, axial loading or compression injuries like a diving accident or a fall from a height greater than the 3 feet, like they fell off a scaffolding or something, a barn. Those would be significant high-risk injuries. High-speed motor, I still can't talk tonight. High-speed car crashes, especially if there's a rollover and ejection of the patient. Another time that we might consider it high risk is if there was the death of a patient in the same vehicle. We might consider that. Okay. Energy forces that move the spine beyond its normal range of motion, whiplash, and those types of things. When we've got a patient that has osteoporosis or some brittle bone disease or some of those other things, we can have patients at a higher risk under less mechanism of injury. So we don't really set this is what we consider high risk, because if you've got a little 84-year-old woman that's got osteoporosis and she's all kind of curved and bent, obviously it's going to take less to damage her bones than it would be somebody that's more healthy. Okay. On the flip side, there is a condition called osteogenesis imperfecta. I have a paramedic student at this point in time that has 3 children, and they all have osteogenesis imperfecta, which is a brittle bone disease, and it takes very little. You might grab their arm to hurry them across the street and break their arm. So generally, if you've got patients like that, you're going to have people around that know about it. But occasionally you get on scene and there's nobody there that can talk or knows about this patient. So just know that those things exist. So high risk are ATV and motorcycle crashes, because generally there's no protection around those. And bicycle collisions are amazingly high risk. Okay. So if there was a vehicle involved, that puts our mechanism of injury much higher, and we want to worry about our patient's well-being at that point. Okay. So so pain and tenderness are important findings. What we're looking for is we're looking for deformities, we're looking for pain and tenderness, we're looking for any neurological deficit, okay, and we're looking at their mental status. Okay. So if they have paralysis of their extremities, they're getting C-colored and boarded. Okay. If they have changes in their neurological function, they're getting C-colored and boarded. If they have pain with or without movement, that's an indication to take spinal precautions. Okay. Impaired breathing, tenderness anywhere along their midline spine. Okay. If we notice any deformities, that would be one. Now, if they have an altered mental status, whether it's drug or alcohol induced, whether it's increased intracranial pressure, whether they're unconscious, or if we have a language barrier, we're not going to know if they can feel their extremities, because we can't guarantee that they understand what we're asking to tell us. So if that's the case, we're going to take spinal precautions if there's a mechanism of injury there. Okay? If we find none of this and their mental status is fine, then we could think about not immobilizing them. Okay? Some things that we can look for spinal cord injuries. If they have loss of bowel or bladder control, that is a sign that there's been a spinal cord injury. Okay? If there's a deformity along the spinal column, then we can think about a spinal cord injury. Another thing that is indicative of a spinal cord injury, and it's not something that you would think, but it's called a priapism. And in males, it's an erection. But generally, being in like a car crash isn't generally something that should sexually arouse somebody. So a priapism is generally the patient's got some neurological deficit along with that, oftentimes, or they're unconscious. So if you see that erection when they probably shouldn't have one, start thinking spinal cord injury. And then neurogenic shock. And neurogenic shock is when the spinal column has been severed, so it's not communicating to the lower part of the body. And so that lower part of the body then kind of goes on vacation because there's nothing there to tell it what to do. And so what happens is those vessels get huge, and our blood pressure can drop, but we also have no ability to tell our muscles to move. So we have paralysis below the point of the injury, and usually no ability to feel at that point also. So those things all point to spinal cord injury. Okay. Now, keep in mind that our geriatric people, again, are a little bit different. So they have brittle bones, and sometimes those bones fracture and cause the fall. So not that it matters when we get there, we're going to be dealing with the results of both, but sometimes doesn't take much force or no force to fracture a bone. Okay, so when we go through our assessment, remember, as we approach our patient, we're thinking spinal immobilization. Get that done. Have your partner grab spinal immobilization. You do your ABCs. Make sure that we've got an airway. Make sure that they're breathing adequately, that they have an acceptable pulse, and there's no hemorrhaging. Okay. Once you've got those things done, and that their A also includes AVPU, that their mental status is okay, then we can go ahead and do a quick assessment of their head and neck. So put your hands in there, palpate, get through there, look for bleeding, look for lacerations, look for deformities, contusions, abrasions, puncture wounds, burns, swelling, tenderness, all of that stuff. Once we've looked at that, we're also looking at the neck. We're looking for the trachea to make sure it's midline, and we're looking for JVD. And then palpate that spinal column in the back of the neck prior to putting on your C-collar. That way you don't have to take it off later and do it again. Okay? And we're going to look for CSM in our patients. So check CSM in all four extremities. Okay? We're going to immobilize them with the appropriate device depending on what your patient presents like, what their primary assessment has indicated, and what predicament you find them in, and then recheck our CSM. Okay. So low-risk patients, like we talked about before, sometimes you get those patients that really don't have a great mechanism of injury, but because of their medical status can be injured. Okay. Secondary injuries. So our primary injury is caused by the actual force itself when it impacted our patient. Secondary injuries are now known. We used to think those secondary injuries were caused by moving our patient around too much. Now we know that it's caused by hypoxia, that we're not watching our airway close enough and providing ventilations or oxygen when it's appropriate, that it's caused by shock and hypoglycemia, so low blood sugar. So what we want to do is we want to prevent shock, and we want to handle it when it does present. So 2 rules, okay? With your trauma patient, we're going to assume they're bleeding, either internally or externally, until we can prove otherwise. Okay? Secondly, we have to keep them warm. If you've got a patient that goes into shock and it's from a traumatic injury, and you let them become hypothermic, there's a very great chance they won't survive. So when a patient goes into shock, they lose all ability to maintain their own body temperature. So let's just jump on the bandwagon and do that for them. I don't think that providing oxygen and a blanket to our trauma patients is ever going to hurt them. So jump on the bandwagon with that and treat for shock. Okay. Our terminology in Iowa is we call it assessment-based spinal immobilization. So we're going to immobilize our patients based on our assessment findings. This is going to cause you guys to have to think critically and not just say, oh, I see this, I have to do this. We need to think about what we're looking at. We need to think about, could our patient be seriously injured, and are there any indications that they are? Okay, and again, pad the voids, because that spine is curved. We don't want to lay it completely flat. We're going to cause a lot of pain, and we're going to cause more injury. Okay, so we're going to immobilize the head. We're going to size our C-collar, and we're going to always use a C-collar in conjunction with another device. So head blocks, towel rolls, something to keep their head from moving. Okay. Excuse me. Okay, our backboards are useful, okay, but there's nothing magical about a backboard. The things that a backboard is going to do is cause a lot of pain. It's going to cause some pressure sores in pretty short order, especially on our geriatric patients. It does make it easier for us to lift and move our patients, but if it's going to cause our patients a lot of pain and cause more damage, there's no reason for us to leave our patient on the spine board. So think about it for moving, and then move them off of it and put them right on the cot, unless you've got some deformity or reason to believe that they need to be on the lungs backboard. Okay. Vacuum mattresses are much like our vacuum splints and are extremely comfortable. They conform to all the patient's curves and bumps and work really, really well. Again, no, they're kind of expensive, so if you take them to the ER, you make sure that you, number one, tell the ER nurses how to operate it, and number two, make sure you get it back. Okay. So patients who have been hurt and they're subject to spinal injury can be found in many different positions. So make sure when you put your C-collar on, it's the right size and that it's appropriately ready to go before you put it on. They can impede the airway if we don't do that correctly. I've been called to several locations to tier with basic squads, and I have found the cervical collar has been put on upside down. And really there is no excuse for that. You need to know what you're doing. If you're not really, really comfortable with C-collars, then drag one out and practice with it until you get comfortable. So with our babies, use a pediatric collar if there's one available, okay? If you don't have one that small, you can certainly use a towel roll or a little rolled up blanket. If you've got a child or infant under the age of like 6, then we need to pad behind their shoulders to make sure that their airway stays in a neutral position, okay? Car seats do make a great immobilization device, okay? So we can add towel rolls as needed to stabilize their head. However, if their car seat has been involved in a car wreck, it's not, what do I want to say here? We should probably think about using something else to immobilize them, because that car seat could be damaged and will no longer be guaranteed to be useful to protect them. Okay, so if we've got a low priority patient, okay, their ABCs have come back fine, there's no life threats, they just have some pain, and we want to take our time getting them out to make sure that we don't move them any more than necessary and cause any more pain, then we can use that short board or that vest immobilized device. We call that a KED a lot of times. A Kendrick's extrication device is the brand name for that. It requires a lot more time. They're very cumbersome and quite honestly are very rarely, if ever, used. High priority patients, we're going to maintain manual C-spine. We're going to move them onto the long spine board, and we need to think about rapid extrication. Now, in your skills videos for this week, there are videos on how to do both of those. There's a KED video, and there's also a rapid extrication video. We're using 2 or 3 responders, and there's also a rapid trauma assessment video. I encourage you to watch those. Okay, and here we are trying to put that lovely KED on this patient in a car. Luckily, there's no roof on this car, and we've got lots of access here. They still are kind of a pain in the neck to do, but can be used if necessary. Okay, so applying a backboard, there's also a skills video on that. I think we've all practiced it in lab. So log roll your patient. Make sure that you think about putting a blanket on the board before you move your patient onto it. So if you've got a little extra time, if it's not a high priority patient, just laying a blanket on there is going to make that trip for them, if you're going to leave them on the board, so much easier. Okay, and then if you're going to leave them on the board, think about putting a pillow under their knees. That will take the pressure off of their lower back and make that ride 1,000% more comfortable. So we're going to pad the voids between the board and the head and the torso. If you have a very small patient, you're probably going to want to pad the voids between the sides of the patient where the straps come across so they don't slide back and forth. Okay. We're going to secure the head and the extremities, the extremities and the torso, and we're going to secure the head last. That's an absolute must, is securing that head last. If we have a pregnant patient, then we're going to tilt the board to the left a little bit after immobilizing, and that's going to take the pressure off of that vena cava so that we don't impair their circulation. Okay, and we're going to put a chest strap on, a strap across the pelvis, and one across the thigh to immobilize them snugly. Okay, if we're using having a patient that's 6 years old or younger, and that's just kind of a guesstimate, think about padding beneath their shoulders to compensate for their large head so we don't tilt their chin down and make their airway compromised. Okay. Again, the KED is a great immobilizing device for kids because you can wrap it up around them. They feel secure. It's got handles on it. It tucks them in there nice and snug. Okay. And again, the car seat is no longer recommended if it's been damaged in the wreck. Okay, so your rapid takedown, the standing longboard, we practice this in lab. There's also a skills video on it in your skills video page on this week's course page. So it takes at least 3 providers, a cervical collar, and a long backboard. So I encourage you to watch that. If you haven't done it in lab, make sure that you do that. Okay. Now, on patients that are wearing a helmet, okay, leave the helmet in place when it fits snugly. Okay. So if your head's in there, it's nice and tight. Such as I've posted 3 videos of helmets removal on your course page. So if you've got a helmet like football helmets, they're designed to fit snug. They have a purpose, and they can't meet that purpose if they don't fit. So if it sits snugly and it's there, leave it in place, especially if it's a football helmet and they have shoulder pads on. If you take the helmet off and they still have pads on, you have got to pad under the head or you're going to hyperextend the neck. Okay. So if there's no airway issues, breathing issues, if we think that moving this helmet off might cause further injury, if we can immobilize them with the helmet in place, then leave it on. Okay. But if we can't manage or assess the airway, if the helmet doesn't fit them properly, or if they're in cardiac arrest, that helmet's coming off. Okay, And you've got skills videos to show how to do that most effectively. And that is it. I've talked your leg off long enough. I hope you have an awesome time, and looking forward to a good wrap up in this course. So we will talk to you soon.